when the clock on the slide reads 4 o'clock, I'm going to stop sharing the slide and you can begin whenever.
How cool is that? We've got the flyer here. It's got the order that we ended up with. Welcome everyone to the 2021 Hawaii Book and Music Festival. This is the Wellness Panel and a discussion on lessons for the future pandemics, lessons for the next pandemic and moving forward. What have we learned from this trying time and really this journey of discovery with COVID-19? We have a distinguished panel today, and I'd like to offer a brief introduction. There's Jonathan Dorkin, an infectious disease specialist on Hawaii Island. He has advised the mayors of Honolulu and Hawaii counties, and he's also the author of The Plague Doctors, How Hawaii Battled the Pandemic. Welcome, Jonathan. We have also Dr. Ellen Buenconsejo-Lum. She's at JABSOM, an associate dean at JABSOM, and the chief liaison between the university and various state entities on the matter of the pandemic. Also with us today is Dr. Thomas Lee, assistant professor of epidemiology at University of Hawaii, and he served for the Hawaii Emergency Management Agency as state's lead modeler and forecaster. He's also assisted the governor to formulate policy and is working as a medical planner for the U.S. Army Pacific. Finally, we have Nick Redding, the executive director of Hawaii Data Collaborative. His background is in social and organizational psychology from Columbia. Welcome, everyone. Thank you. Dr. Dorkin, you wrote the book, The Plague Doctors, How Hawaii Battled the Pandemic. What have you learned? How can you counsel us on lessons learned for the next pandemics?
Thanks, Ira, and thank you everybody for having me. It's a real honor to be invited onto the virtual stage with such a distinguished group of Hawaii scientists and fellow physicians. My own role in this starts as a clinical infectious disease doctor. And like a lot of other clinical docs, in February and March of 2020, I was sweating, seeing this thing coming at us and trying to wrap my head around how it was going to impact the state, how it was going to impact my clinical practice, and what the level of disruption was going to be. And very early on, there was a lot of confusion. The topic of this panel is preparedness for the next pandemic. But I think before we can really assess that in an intelligent way, we have to first try to frame whether or not we did what we wanted to do during the current pandemic and accomplish what we needed to accomplish. So I have a few slides here that I'd like to share that come directly from the book. And the book is part memoir and then also part analysis of how Hawaii did. So I want to share some of these because I want to try to put into context how we did. And I want to assess our performance and see whether or not the orthodoxy that Hawaii has done as well as it's done is actually holding up. So I'm going to try to share a screen here. And this should be viewable now. So one of the things I did with the book was I looked at deaths and tried to compare Honolulu, which is the big metropolitan area in Hawaii, to other metropolitan areas in the United States. And this is data through March of 2021. Around spring, we start to see big discrepancies based on things like vaccination rate, particularly internationally. And what I was trying to get at was what was the effectiveness of Hawaii's public health policy? How did we do with non-pharmaceutical interventions, things like mask wearing, border control, various movement restrictions, all of the inconveniences we put up with as a state? And how did we do? And if you compare Honolulu to other metropolitan areas, it looks pretty good. Here you see New York, which had one of the highest mortality rates in the country. And then here's Honolulu all the way at the bottom. And based purely on that, it appears that Hawaii was the success that we're often presented as in the national media. It's a little bit more complicated than that, though. Here's a slightly different graph. And what I did here was I separated Hawaii from the United States. The two dark black lines are Hawaii and the United States population in general, the United States death rate in general. And then I compared us internationally. And what you see is still pretty good compared to the United States. But if you look to the left, you see countries that did significantly better than Hawaii, and many of them are our neighbors in the Asia Pacific region, right? So Hawaii shakes out, somewhere in the range of some of the better organized Scandinavian countries, but not nearly as good as Japan, Australia, South Korea, and nowhere in the same ballpark as New Zealand or Taiwan, which barely register on the graph. These are, island nations in the Pacific as well. Within Hawaii itself, though, you see a lot of discrepancy. So this is a graph that I think illustrates what might have actually been going on here. The dark black line is Maui. And this is cases, not deaths now. The light gray is Kauai. And what you see is prior to October 15th, if you look at the far left of the graph, both Maui and Kauai, and the reason why I choose these two islands is because they basically had very little transmission when we were under the mandatory 14-day quarantine. So these are islands that had very limited local transmission. And then on October 15th, we begin to open up. And what you see is both islands experience an increase in cases. And we're not talking about a huge case incidence here, but noticeable compared to the baseline, which was almost zero. And then on December 1st, Kauai withdraws, but Maui stays in. And what you see is the epidemic essentially extinguishes itself on Kauai, whereas you continue to have significant transmission on Maui. And this graph continues through spring of 2021. So, one thing I want to express is my admiration for the people of Kauai, who I think amongst everyone in the state really imitated and in some ways even exceeded the best countries in the world in terms of disease control. But it came at a cost to their island. We know from economic data, for example, that their unemployment rate was higher by the spring, and that they paid a significant cost for this success. And most of the rest of the state followed a more Maui-like pattern and accepted a certain amount of disease, transmission, and death in exchange for a limited economic opening. and all the attendant problems that came with that, including now what we're seeing with the resentment of the tourism industry and whatnot. So the question is, could we have had a curve that looked more like Hawaii or New Zealand or Taiwan with less attendant economic destruction? And that's kind of the crux of what I wanted to get at. This was a picture I snapped when I flew into Hilo Airport during the winter surge, and it was in between flights. This was post-arrival testing on the Big Island that was established by Mayor Harry Kim during the winter surge of cases. And what I noticed was this picture was taken when there was nobody in line, but this line could go from 0 to a couple hundred people very quickly. And trans-Pacific travel resulted in a post-arrival rapid antigen test at the airport. And this was an attempt, I think, to do what Hawaii was doing while allowing more travel to come into the state. And it was somewhat limited. It was at the airport. It wasn't at the ideal interval of time, which would have been, 3 to 4 days post-arrival. And, the other issue with it was that it was stopped around the springtime, and it never became a universal policy. So what this gets me to is, what is real excellence in pandemic control? And I was thinking about this in advance of the panel discussion, and I, for myself, defined a few things that I would think of as excellence. Excellence is our case in mortality graph, the entire states looking more like Taiwan and New Zealand, not the US mainland. That should be what we're trying to accomplish. Excellence would be kids in schools and local businesses open. Excellence would allow for travel at a modest volume, but ensure that it's safe, and it would do that efficiently. And excellence would also involve an investment in the long-term viability of Hawaii infrastructure, including biotechnology and software, which we never really stood up. And finally, I think this is as important as everything else. Excellence is social cohesion. It's an awareness of our history. It's an awareness of what happened to the Hawaiian people and why we have an obligation to make sure that something like that never happens here again. And excellence is people having reason to trust our institutions and cooperating with our attempts to control the disease. So that's how I wanted to try to frame the discussion of Hawaii pandemic preparedness. And since there's so many other smart people who need a chance to talk, I'm gonna leave it at that for now. Thank you.
Thank you, Dr. Dorkin. Excellent review. Thank you for some excerpts from the Plague Doctors, How Hawaii Battled the Pandemic, your recent book. And most notable is your broad-based social, cultural, economic, and healthcare definition of excellence. Thank you for that. The next talk is by Dr. Ellen Buenconsejo-Lum. She is a chief liaison between the university and a number of state organizations and serves as associate dean at JABSOM. Dr. Buenconsejo-Lum.
Hi, aloha everyone. Thank you so much for inviting me to this panel. And I've worn many hats, and so I think hopefully I can offer complementary perspectives that will help us really answer the question, how can we better prepare for the next pandemic? So I am at the medical school. I am a family physician by training, and my scholarly work has really been focused on the U.S. affiliated Pacific Islands. And so I've worked with our colleagues in the USAPI for over 20 years, and therefore come from a frame of capacity building and true community engagement, and really looking to empower and build partnerships so that the whole of society can be stronger. And so that was kind of the framework that when I joined the effort in early April. And so I was a part of the HI-EMA ESF-8, which is the Emergency Support Function 8, which is really the part in emergency management that deals with health, public health, and medical care. And as a liaison representative, I could comment on whatever I wanted and get asked to do whatever they needed me to do. And so it was definitely a busy spring, and I was certainly not alone. There were many colleagues from UH that participated quite actively. I played a role with Dr. Chris Qureshi in standing up a community care and outreach unit, who was really charged to try to identify the impacts, current and future impacts, both on organizations, and including organizations that serve, those that were already being hit the most hard, but then also the impact on individuals. And so our CCO unit had some key community partners from the Native Hawaiian, Pacific Islander, and Filipino communities. We also engaged key folks from the neighbor islands, from the different district health offices, and were able to conduct 2 surveys. The results of those are actually just published in a special issue of the Hawaii Journal of Health and Social Welfare. So that was one thing. And then a very quick apparent need was for the truly homebound elderly, because they were not able to get they're homebound. And so as the state was getting more access to testing and other things, they didn't have an easy way to do it. We were still experiencing PPE shortages, and we're dealing with vulnerable populations. And so how do you make sure that they have PPE and the appropriate training, and really all of the ultimate goal was to keep them out of the hospital. And so with that, we partnered with the hospice agencies and the home health agencies, partnered with Queens and HPH, who by that time had stood up their virtual COVID hotlines, which served as a resource to answer questions, but also manage people as an outpatient. So we tried to help with that question. And then, of course, bringing in, helping to coordinate the resources of the university to support all of the different efforts. And then, October came around and vaccine came around. And so I helped, serve on several different vaccine implementation committees, including looking at from the provider side. So, we all know we've got, big health systems with networks, but there's also a lot of folks, especially on the neighbor islands, who may be in smaller practices, who may not have the capacity to provide vaccinations, yet the community trusts them. Right. And so how do you really bridge that? And so that's the provider group, and then, medical advisory group. I'm the co-chair of that. So I guess my lessons learned, are that community engagement is important early. And I think we could have done better with that. And, that is definitely reflected in all of the early data, with showing a huge disparity with the Pacific Islander group, getting COVID. They represent 4% of the population, and at the peak, they were about 31% of the folks getting, positive testing. And we also see that reflected both in hospitalization data and in death data. And that was early on. And then this spring, after the advent of vaccinations, then unfortunately we saw that shift a little bit. And, with the Native Hawaiians, suffering disproportionately, and Filipinos. And so I think, getting the community engaged, meaningfully engaged and at the table are important, because many of these solutions are going to come from the community. And, so certainly for the vaccine, there's a Kupuna working group, because the needs of the Kupuna are very different than the needs of ambulatory younger people, and the needs of businesses and for work sites, and how can they help keep that, so everyone's needs are different. And so it's important to set up infrastructures and communication structures so that everyone's voice can be heard and thought about very deliberately and very strategically. because we had to make some very tough decisions about, prioritization, right? Who's going to get the vaccine first when we were in a, short supply. And, we're certainly obviously guided by the CDC, but Hawaii's complexity meant that on the prioritization working group, we actually had a very, very difficult situation because we couldn't just use the CDC's criteria. We actually had to tailor it to Hawaii and look very closely at our demographics and delivery and important issues of equity. So infrastructure, community, and then partnerships is really, and making sure that we truly have the infrastructure to support and sustain partnerships. I think the biggest lesson has been the public-private partnerships that really had to emerge because initially in the early phases, it was very, very clear that the state couldn't do it alone, nor could the health systems, right? And so it really took everyone to do that. And I think that's been one of the strengths, certainly those early days, were rough. Everyone was really stressed out and stretched and dealing with workforce outages. But again, keeping that infrastructure, that communication infrastructure in place. And then, the last is the policy and, the time it took to set up different agreements, even between UH and the DOH, who are sister agencies, sometimes, you want to be compliant and all of that. And so I think we have a lot of good lessons learned that, I think could be put in place so that we can be more agile in the future. So I'll leave it there. Thank you.
Thank you, Dr. Buenconsejo-Lum. We just heard from our Associate Dean at JABSOM and Chief Liaison between the university and state agencies, talking about this panel is one of the wellness panels, and it's on lessons learned from this pandemic, lessons for future pandemics. Thank you for stressing the importance really of community engagement, consensus on priorities, public-private partnerships, and agility. We first heard from Dr. Dorkin, author of the Plague Doctors, how Hawaii battled the pandemic. Thank you for your insights. Move on to our third speaker, Dr. Thomas Lee, Assistant Professor of Epidemiology at University of Hawaii. He served as the Hawaii Emergency Medical Association as state's lead modeler and forecaster, assisting the governor as well. Dr. Lee, what can you tell us?
Hello, everybody. Thank you for taking the time to listen to us, and an honor to share this virtual stage with such distinguished colleagues and scientists. I haven't been able to teach for a while. I've been on active duty, so chance for me to say this is me speaking as a private citizen and not as a military officer. I have to get that out of the way. I've had the pleasure of working directly with Dr. Buenconsejo-Lum within ESF8, man, it feels forever ago, but April of last year, and then also with Dr. Renning and his team at Hawaii Data Collaborative, with the data piece. So a quick background, my role, Coconut Wireless, everybody knows how small Hawaii is. I was teaching my global health class, telling my students, hey, in the news in January and February, hey, there's something called COVID, let's keep an eye out for it. And then I distinctly remember our last class right before spring break saying, hey, this could be our last class in person. And unfortunately, that couldn't have been truer. So, I assisted a fellow colleague at JABSOM. She had some contact tracing questions. And then, it just ended up, I was asked, hey, do you want, we need an epidemiologist. There's a pressing question for the state. Do we need to stand up the convention center as a field hospital? That was the originating question for the epidemiologist. And then so I willingly said, hey, let's take the plunge to support the community, and let me try to leverage my epi perspective, which I will say is different from my colleagues on the panel. I look more at population health. I don't have the expertise to look at the clinical side, though I do look at a lot of the findings there. So lessons learned, what I remember telling my students and doing in the early interviews is, what success did Korea, Taiwan, Japan have? And what set them apart initially was their prior experience with SARS and MERS. They they experienced something similar. So to Dr. Buenconsejo-Lum's earlier point, they created policy which positioned themselves to react much quicker for COVID than a lot of other countries, United States, to name one of them, were able to do. So one example was they had standing MOUs with private companies to start cranking out testing kits to cut some of that bureaucracy. And the three pillars: testing, contact tracing, and isolation quarantine. Until we had vaccines, until we knew more about the disease, that will always be the tried and true infectious disease and epi method. So they were able to implement that, and then throw on the technology of they had versions of Aloha Safe, from day one or day two, and it took us quite a bit of time to get up to speed and utilize technology, understanding the uniqueness of Hawaii. So just lessons learned, and that's a good segue into the safe travel. So my lead role when I was on orders to support Hawaii Emergency Management Agency was to provide a perspective of what is COVID going to look like in terms of a forecast. And really, I took my role was twofold. One, to provide that service, but a step back was to just provide some epidemiologic understanding to the policymakers to help them understand disease transmissions, and what they could and couldn't believe from some of the sites, CNN, et cetera. So it's important to note that in April, there was no Hawaii specific model that was accurate. The only one that was created was by University of Washington IHME, and their methodology had us peaking and being overrun in our healthcare system, I think 3 weeks into April. What I worked with our team at ESFA was using a very basic infectious disease model where there's no way, based on the epi information we knew, and there was very little at that time, that we would surge based on significantly the early action that the governor took to really shut things down. And we understand the economic consequences, but from a pure public health standpoint, that really saved us from some of the heartache that our sister states on the mainland suffered. So lessons learned, we reacted quickly relative to other states, however, it came with a significant cost. So, my hope from an epi perspective is from a testing and tracing strategy to continue to learn and fine tune Safe Travels Hawaii, Aloha Safe app, utilize technology that we have to leverage testing, contact tracing, to sync all those things together, and our isolation quarantine efforts, and to know that as technology continues to evolve for COVID, we're at a point where at-home test kits are becoming widely available, prescription and non-prescription over the counter, and eventually, hopefully, we'll have a spit test. It's a very cheap way, rapid test. But what I'm looking at from an epi perspective is, as more people get vaccinated, as people continue to get infected with the disease, but have mount a strong enough immune response, the number of daily cases will cease to be as important and really shift to, okay, how is our hospital system doing? And then Merck had some really great news. They cut short last week. They cut short their phase 3 trials of a pill form of an antiviral, which is going to be, I think, a game changer. You couple that with vaccinations, non-pharmaceutical interventions, and are trying to test it. So once again, I think from lessons learned, we did fairly well. We didn't do as well as Taiwan, but we were more forward-leaning than some of our other sister states. And I have a few more minutes, and I would be remiss as an epidemiologist not to talk about herd immunity and variants. And so, I think it's safe to say, 4 months ago when Delta and the Alpha variant were rearing its head, we didn't really take it as seriously. And so, the world and suffered for it, India first and foremost, and then we didn't really react quick enough. Right now, scanning from what little resources we have, I'm not seeing the Delta variant of the fall yet. But that's why it's important to continue to improve our existing systems. And I want to highlight, and I have to switch to my slide. I want to highlight that the federal government stood up earlier this year a National Center for Epidemic Forecasting and Outbreak Analytics, and the goal of that is to have continued and ongoing surveillance so that we're not surprised by future variants, but we're also not surprised by the next COVID, whatever virus that is, because we know speed with which we react is so important. So just want to talk about variants briefly, and then, herd immunity. I think it's still too early to know. Is it 90%? Is it 80%? But what we do know is that we have highly effective methods of preventing and treating the disease through both pharmaceutical and non-pharmaceutical interventions. So I think, chasing after some sort of percentage is less important than just continuing to educate the public in terms of the evolving science of COVID and how we can continue to support our healthcare professionals and our healthcare system. So I want to give back a couple minutes because I'm looking forward to a robust discussion with our panelists. So back to you, Dr. Zinnan.
Thank you very much, Dr. Lee. Excellent. Dr. Lee's assistant professor of epidemiology at UH, and as an epidemiologist, he really covered this question of what lessons have we learned from this pandemic to help us with future pandemics. Spoke about the success of Taiwan, Korea, Japan, New Zealand that dealt with SARS in the past, and the importance of tracking and testing as well as quarantine, and the fact that Hawaii did better than most areas in the United States because it reacted quickly but at significant cost. Fascinating. The first two speakers were Dr. Dorkin, who wrote the book The Plague Doctors: How Hawaii Battled the Pandemic, and Dr. Ellen Buenconsejo-Lum, who's Associate Dean at JABSOM and liaison with the state. Our final speaker on the panel, before we have I think what will be a rich discussion, I have some questions, is Nick Redding, the Executive Director of Hawaii Data Collaborative. His background is in social and organizational psychology with a PhD from Columbia. Dr. Redding.
All right, thank you very much. It's great to be with everybody here. Great to be talking about lessons learned from the pandemic, with the idea being we're moving on from the pandemic. We at the Hawaii Data Collaborative engage in partnerships to make meaning from data for solving Hawaii's pressing challenges. So my take in this panel is going to be a little different in that the perspective I'll be bringing comes from what we learned in supporting the data needs of those working to respond to the pandemic across sectors and topics. So 3 major lessons for the next pandemic: timely quality data matters, data connections matter, and data systems matter. So when we talk about the extent to which timely quality data matters, I want to really zoom out to say, when have we ever seen so much interest in data and the extent to which data is translated to achieving the outcomes we all want? There wasn't anybody in the state that wasn't paying attention to data. It allowed all of us to understand what was happening and what needed to be done, because everybody had a stake in the outcomes. And the data needed to be good, and it needed to be timely, and there was no patience for deviance from that expectation. And so my hope from this is that the lesson learned about timely quality data matters can be a wedge that we keep going forward in terms of the important data in terms of all the challenges we face, whether it's crisis challenges or chronic challenges. Timely quality data matters for achieving the outcomes we all want to see. Data connections matter. When we talk about data accessibility, it's not just about can we get to the data? Is it posted somewhere on some website that we can bring down? But also, does the data have utility for our decision need? And then most importantly, does the data support the meaning making that we need to do? Shared problem solving necessitates shared meaning making at its core. Data helps us all ensure that we're talking about and measuring ourselves against the same thing. So meaning making should never sit in one place and with one organization. Our data should serve this purpose. So we did see, a good amount of COVID data connections that came together very quickly and quite effectively in a short amount of time. The ESF groups of course, have been mentioned, but also numerous private-public partnership groups around housing, food security, childcare, et cetera, other secondary kinds of issues that came up as a result of the COVID mitigation measures. We saw other things like HI-EMA that Thomas is a part of, where a group of local concerned experts took the data that was available and extended it for predictive insight to start to bring more meaning to what we could expect. You know, what did we mean by flattening the curve? What can we expect in terms of the hospitals and other things that kind of lag behind the counts we were seeing? And then there was another effort, still is another effort, COVID POW, which took the data and did a lot of work on the communication side to translate that data for a wider audience. You know, and both of those are examples of trying to kind of lighten the load or take a lift in terms of the COVID data and communication needs from the state. And lastly, data systems matters. State data systems are challenged to support agency work within state data sharing and external data collaborations. And we all knew that. Anybody working on issues that relied upon interfaces with state or state data kind of knew that. But the pandemic really illustrated how critical it is to support modernization efforts. And those modernization efforts have been there. There's a strategic plan. They're still underway. But that, you know, this added to the urgency behind that. But it's also, it's not just the technical capabilities that need to be enhanced, but it's also the supportive capabilities that make for a robust data system or robust data systems. It's the skills and the bandwidth of those who manage the data and make use of the data and are gatekeepers of the data, and the supportive policies that allow them to do that effectively. Of the many things I could talk about that would make a difference on that, a conversation that's come up at least twice in previous legislative sessions is around the chief data officer. This has been advanced previously. I think it might be coming up in the next session. And essentially, a chief data officer is the counterpart to the chief information officer. They're helping us think as a society, as a state, strategically about the role that data plays, how we can enhance our data systems, and how we can start to support agency goals around the data work that needs to happen internally. Imagine if we had something like this in place in a time of crisis like COVID, the role that a chief data officer could play in responding very quickly to the needs of the agencies, the connections between the agencies, and the data sharing needs out to everybody else who really would have benefited from the data that was available. This is something that can be done and brought to life in parallel with modernization effort, which would then also make technical modernization more effective. So, you know, in summary, good quality data matters. And when we don't have it, we're not able to effectively respond to pressing challenges. Data has broader utility than where it sits, and the extent to which we are all able to connect through data enables more effective action. And our data systems and capabilities are far from adequate at this point, given what we actually need. And the sooner we address the data systems limitations, the better prepared we'll be to confront the challenges we face going forward, including the next pandemic. If any of this high-level kind of overview of our lessons learned from data challenges in the state is interesting to those on the talk today, I encourage you to go to our website at hawaiidata.org. We wrote a report about this where we actually went out virtually and spoke to many folks across sectors and domains of interest to get their perspective on what are the challenges and what are the opportunities with our data and data systems. Thank you.
Thank you, Dr. Redding. This was Dr. Redding, Executive Director of Hawaii Data Collaborative. He's a social and organizational psychologist from Columbia, training Columbia University. We're talking about the lessons learned for future pandemics regarding COVID. And Dr. Redding spoke about the importance of data, timely data, the connections we make with data, and data systems that, you know, that to the extent that actually we have a chief data officer in key organizations that's a counterpart to the chief information officer. Thank you, Dr. Redding. We've now heard from our four panelists, the other three being Dr. Dorkin, who wrote The Plague Doctors, How Hawaii Battled the Pandemic. Dr. Lee Buenconsejo-Lum, HI-EMA. We have time now for questions, and I'd like to start out with this question. You know, back last July, I advised the lieutenant governor, and we had a long debate about the pre-travel testing, and I was in avid disagreement with that program because I thought too many cases would come through. You know, if we test people within 72 hours before, what about all the people that were exposed that didn't become positive yet? What about all those that get exposed on the plane and become positive later? And I proposed a 414 program where people would get pre-travel testing, but quarantine for 4 days, test again. And if they're clear, they're clear. But still somehow Hawaii surge bullet at that time. What do you make of that? I think the panelists have a thought on that.
I'll take a quick stab, but I see Dr. Dorkin has a nice smile. So I remember that situation quite clearly, and so I think, you know, it's crazy to know that even, you know, 8-10 months ago, there was still a lot about COVID we didn't know, and so we were making a lot of assumptions, at least from the modeling. Scenario-based perspective, you know, creating different scenarios based on how many test days you're testing, to your point, Ira. And what was hard to really factor in was the psychological and the social response to any type of safe travels, whether it's one test or two tests. And I think what the impact that it had was, at least at a majority of the population, it really changed their outlook and it changed their behaviors. And then, you know, understanding that we could never reduce the risk to zero, we would always have cases that slip through. I think it changed the dynamic of the population that was going to fly to Hawaii. But once again, that's something that's almost impossible to measure. So I think that's where we saw some success, but obviously, you know, it's hard to quantify because there was no formal, there was not a lot of formal studies done to really prove whether or not that worked or not.
Yeah, at the risk of stepping into the virtual poo here, I can say this is one of the most contentious topics that's come up in Hawaii through the whole pandemic, and I can tell you what I saw as a clinical infectious disease doctor, which is that, you know, during the winter surge, the cases we were seeing in the hospital, most of them were travel related. Now, here in rural Hawaii on the Big Island, we weren't seeing a lot of cases. So I think I accept the contention that having a pre-travel test was at least partly effective. And to be fair to the safe travels advocates, it wasn't just a pre-travel test. There was also symptomatic screening and whatnot. So there were a couple of different layers in there that, you know, if my friend DeWolf Miller were here, he would talk about multiplicative benefit of having different layers in the scheme. But what I saw with my own eyes was that there were definitely people getting through with false negative pre-travel tests, not in high number, but it was happening. And the majority of cases that I saw were often relatives of people who had traveled and come back and infected their family members. Right. And these were people who had pre-travel tested negative. And then, you know, presumably some of them, you know, and I tried to tease out the social histories, some of them had done the test and then gone to their social event and then got on the airplane. Right. Some of them had done their social event just before doing their pre-travel test and presumably were still incubating virus when they tested negative and then came through. Some of them may have been infected during transit. So this is what I saw. And the issue was not the pre-travel test. The pre-travel test is fine. You know, on the day that you're tested, the sensitivity of a pre-travel test is good. And to be clear, I think having a pre-travel test is far better than nothing. And the alternative in June of 2020 was not a post-arrival test and a pre-travel test versus just a pre-travel test. The alternative politically in Hawaii was nothing. It was either we're going to do nothing and we're going to open up, or we're going to have a pre-travel test. So I would much rather have a pre-travel test than have nothing. Now, that said, wouldn't it be better if we could have had something more than that? And what would have made the border control system better? I think it's a combination of things. It's not just post-arrival testing. We never really had quarantine enforcement at scale here. So how are you going to allow people to test out of quarantine if you're not enforcing quarantine? I think the original sin of our border control was the lack of any kind of quarantine enforcement or centralized quarantine, which is what other jurisdictions did that were really serious about border control. You can enforce quarantine, then you can give people avenues to get out of quarantine. If you can't enforce quarantine, then the whole thing is sort of a house of cards that's going to fall down under any pressure. So I think there hasn't been enough attention to that. And, back in February and March, I was banging quite unsuccessfully on the drum of setting up some kind of centralized quarantine system, and it never happened. There was also big discrepancies in terms of what we were seeing. So, even now, if you look at the safe travels data, who comes into the state unvaccinated and untested? The vast majority of the people coming in unvaccinated and untested who are quote unquote quarantining are local residents. And that kind of fits with that anecdotal observation that I had, that local residents came home and infected their family members over the winter. I think that's how the variants got into the state. There's just no doubt in my mind. So what I would have liked to have seen is a more careful consideration of what do we do for quarantine during the next pandemic? And is it going to be this kind of slapdash system that we had right from the get-go? We should have a more organized approach to quarantine. And then we can create avenues for people to get out of quarantine that makes sense, right? So maybe you have a locally developed rapid antigen test and you allow people to take that test 3 days after arrival, something like that they can get out of quarantine. Once vaccination is available, maybe that's an avenue for people to get out of quarantine if you can show that the vaccines block transmission. So you can create a better border control system, but in order to create a better border control system, first you have to put in place the basic building blocks of your border control. And I think we never really did that. And that's the fundamental issue.
Thank you. Thank you. Shifting topics, I'd like to look at health safety versus the economy. And there's some note, for example, New Zealand just announced, well, they're not going to be at zero COVID moving forward. So they're going to open up somewhat. And I'd set up previously business and economic roundtables for the state executive, and these leading business executives were crying bloody murder at the self-inflicted wound of acting quickly and keeping the cases down is concern on the part of business and the economy. Dr. Buenconsejo-Lum, you spoke about the importance of community consensus, public-private partnerships, and so on. I mean, what lessons have we learned from this pandemic for future pandemics that will optimize public safety while not hampering the economy? We're talking not rich people. We're talking people having jobs, people securing food through a supply chain network. So how can we balance those two factors?
Yeah, I think that's a difficult question that unfortunately I don't think we really still have figured out well. But I think it certainly belongs with listening, and not just listening to the community and the businesses, to all the stakeholders, but also really listening to the data and to the science. It's difficult. I wouldn't want to be a policymaker trying to, balance budgets, but yet as a healthcare provider and as a scientist, we know that a longer term look and really looking at from the greater good in the long term is really critical. But yet, our policymakers have a really tough situation, right? Trying to balance the biennium and, decide, which programs are more essential. And, and that's just a really difficult position. But I think that, and someone had commented in the question and answer, I think having an organized framework to really make sure that the science, and this is all science, so not just epi, not just clinical, but certainly the social scientists, the economics, we had a very, hodgepodge mix of people that kind of came together. And initially it really wasn't, coordinated or strategic. And so I would argue that we should be coordinated and strategic and really set up our public health system and our overall health ecosystem, that includes education and includes social services. Because I think then if you have that and it's agile, so I do not advocate setting up another agency because that is not how you are agile. You set up an advisory committee that has clear channels of communication, clear accountability, and clear decision making, like where does the buck stop and why and how, and just transparency, I think, is the other thing that I think got us into a little bit of trouble, at least initially. Everyone was doing the best that they could and running at 1,000,000 miles an hour with something that no one had any experience with. But we certainly learned a lot of lessons about the importance of transparency. And so I think having those things going forward will then set us up so that we can have a more robust, problem solving, but really looking at the short, medium, and long-term outcomes and impacts, because I think we were just so forced to look at the immediate, and I agree that, the shutdown was actually absolutely the right thing to do. No, and we all knew full well, all of us that were in this from the very beginning knew absolutely full well, what would happen. But because we were also in the hospitals, we also knew that the consequences would be what you're seeing in Alaska right now. And we needed to desperately, desperately avoid that situation. So I think having those things in place, having it be science-driven, and just really making really clear who's accountable for which types of decisions, I think would be helpful. So I know I didn't totally answer your question, but.
If I could chime in on this, one other lesson learned from the pandemic, we did a lot of work in the COVID data space, but we also got a lot of requests for assistance in the household needs space. So those trying to find out how to deploy food, housing assistance, and other kinds of basic need resources, and not being able to get at the data they need, the timely data they needed to understand how households were being impacted by the COVID mitigation measures. And we had resources to respond to that need. So the counter to that was, while we did take significant steps for public health purposes, we also had resources to buffer the economic shock. But the challenge we had in supporting our partners was the data wasn't there to help them understand, okay, well, where do resources need to be deployed in that extent to hold everybody over? So that's a lesson learned for us, and that's something we're taking very seriously at the Data Collaborative. Is I think even pre-pandemic, having more timely data on how households are faring and what would help them and how well we're doing in helping them would make a difference. In a pandemic, it would have made a tremendous difference.
Yeah, and then one additional point, Ira, sorry.
Sure.
I think it's important. We've talked so much about, and I wholeheartedly agree with Dr. Buenconsejo-Lum. Everybody in the medical and science field understood the devastating consequences if we continue to shut down. However, based on what little we knew about COVID, it was hard to, it was, immediate loss of life or, long term, which is still devastating. We acknowledge the mental health, the long-term socioeconomic impacts. However, I know the word triage has been in the news lately. However, what we can do, I think one of the major lessons learned is, how do we as a state and as a community learn so that we don't have to shut down per se, right? Where, Taiwan shut their borders, but if you look, they were one of the few countries that actually were in the black for economic growth, even throughout when every other country was being hit. So it is possible, right? So shutting down doesn't mean shutting down our economy. It's just we like Nick said, we didn't have the resources ready to support and the data flows necessary to get the resources to the people who needed it. So I think the goal is to prevent doing that. However, if we need to shut down, like my colleagues say, we need to have policies established so there's a clear strategic plan. So, it includes education, economics, mental health, et cetera, all of our stakeholders, so that, we're not building the airplane as we're flying it.
Excellent, excellent. Dr. Lee, thank you for that insightful point. I'd like to pose a closing question as we think about lessons learned for future pandemics, about where we are today. My take on the data is that a month ago we were peaking at 1,000 plus per day. We were maxing out our hospital capacity at 470 out of roughly 500, setting up field hospitals, getting support from the federal government with providers that have IM monoclonal antibodies. And then it started to back off one week, a little more the next week. Last week was much better, and the latest data is really showing kind of a defervescence of the pandemic, possibly. The first question is, are we really on the way down? And are the mayors and the governor going to have to rethink the mandate and the metrics? And the other question is, if we are down, why is that? Is it because, to what extent is it because people are getting boosters, more people are getting vaccinated, more people are getting COVID and have post-COVID antibodies? We have mandates making us safer, and to what extent are we actually possibly approaching herd immunity that's slowing down the case rate? Of course, the fifth thing is some fewer visitors. So let's take that as the last question.
Briefly, I'll take a stab at it. When we were at peak here in our rural hospital in North Hawaii, 50% of our hospital beds were COVID. 100% of our small ICU was COVID. All of our patients, the day we were peak, were unvaccinated. If you look at the Queen's Health System as a whole, about 10 to 15% of the admissions were vaccinated. And the couple that I saw were people who were quite frail. So boosting is going to help with that population. The question of boosters is who needs to be boosted. And what I would like to see nationally is the data on who's getting admitted with breakthrough infections. I suspect it's people with a lot of comorbid medical illnesses and elderly. Those are the people that we should boost. Otherwise, we just got to get the vaccination rate up. I would support any and all efforts to do that. At this point, we have to think about the pandemic as a moving organism, because what was appropriate in February or March of 2020 isn't necessarily what's appropriate now. It's clear now that the exit strategy is to get our vaccination rate as we possibly can, by hook or by crook, and I would support any and all efforts to do that because I'm the one that has to clean up the mess when people get really sick, right? And I don't appreciate it, frankly. And I think it's a disaster, and it was a completely self-inflicted injury. So, we still haven't gotten many kids eligible for vaccination, which means we're still at risk of having our school year disrupted. So there are consequences to failure here that are still real. Back to some of Thomas Lee's points, I think for the next pandemic, we really should have some reflex memory, and the initial lockdown and 14-day quarantine was absolutely appropriate when we didn't know what we were dealing with. And the goal in my mind would be to transition out of that as quickly as possible to a system that works and that's based on our local infrastructure that allows us to return to some kind of normalcy while we're developing therapeutics, while we're developing vaccination, and not to have to shut everything down for 8 months, 9 months. So leave it at that.
Yeah, I just wanted to add to Dr. Dorkin's great points, in the terms of, on the topic of boosters, I think, yes, this needs to be scientifically driven, not any other policy, it shouldn't be driven by politics. And I'm going to put on my global health professor hat. I think locally, nationally, we want to move on, but I think we're so focused on our efforts here, which we should be, and focusing on our minority populations, our at-risk populations, yet I think we forget where we are positioned in Hawaii as, a major hub for trans-Pacific travel. And really, we're so lucky, even as a nation, to be at a vaccination percentage that majority of the world is not yet there. So understanding that global travel and business is going to continue to pick up, until we have vaccine equity across the world, the risk for Hawaii and the rest of the country to be hit with the next variant or some other infectious disease will continue to be there. And WHO director asked twice for a moratorium on boosters writ large. I completely acknowledge that based on what the science is showing, immunocompromised, defining true at-risk populations for the booster is necessary. We need to keep them out of the hospital, but until we have vaccine equity across the world, that's when we're going to feel comfortable saying, hey, okay, COVID, we're moving over it. Because if not, it's just going to be out of sight, out of mind. It's going to be smoldering in some country in Africa or some other continent, and then boom, it's going to explode, right? And so we're going to have to repeat this process all over again. So that's just my global health perspective.
Dr. Lum, do you have a comment on kind of this global health perspective, and we just alluded now to Africa, which has a 4% vaccination rate. Do you have a comment on that? How that impacts not only Africa but Honolulu and neighbor islands?
Yeah, I would agree wholeheartedly. And I was asked a question by someone the other day. What is the next pandemic, right? And and when I was asked to predict when the next pandemic. So certainly that is not my area of expertise, but it is clear that the globalization has greatly impacted the spread, right? And so if you look at the original SARS, right, and the impact of travel kind of within those different areas, versus now, right? It's completely different. And so until we start to think as a globe, and that means that the richer countries will have to give up some of their vaccine, to some of the countries that don't have that infrastructure yet. That really is going to be the solution. And, I wholeheartedly agree that we are not going to boost our way out of this pandemic. We have got to get everybody vaccinated who does not have a true medical contraindication. And that is that. And then our immune systems, for those of us that have strong immune systems, our memory cells are going to kick in. And, we're going to constantly be re-exposed to something like SARS that shares, 88 to 90% of the same genetic makeup, and we're going to probably be fine. But those of us that are older and those of us that have serious uncontrolled medical conditions are the ones that need the booster. And so let's give it to them, let's prioritize them, and let's make sure that all of the rest of the countries, people think that Africa is so far away, it's not going to impact us, and that is absolutely not true. So, we worry a lot about Asia and, Oceania, but again, the world is a small place now. So yeah, I think vaccine equity is a huge issue, and, slowly, I think too slowly, things are starting to move at the WHO and COVAX, but yeah, just really much too slowly. So.
Ira, you're muted.
Yeah, thank you, Dr. Buenconsejo-Lum. The last word then is the importance of vaccine equity. Lessons learned. Vaccine equity is critical. Thank you to an awesome panel. Great discussion. Great minds. I'm honored to be with you today. A couple of closing comments from Roger Gellinger.
Thank you very much, everyone. Really was a terrific discussion. It's already given me an idea for another panel, which I might even actually put into this program, which is to have people like yourselves design the perfect system for the next pandemic. In other words, not just review what had happened, but actually in an hour, identify and define what absolutely has to be in place as a project. So we'll have to think about that. Anyway, thank you very much, everybody. It's just
Yeah. Strong work. Thank you, everyone. Take care. Bye-bye.
Having me.
Bye, everyone. Stay safe.